So I just wanted to have a few words at the beginning to open this meeting. I'm Sarah Wynne, I'm the CEO of Unique, and I'm really glad to see all of you here today. I've got a sort of Oscar speech of thank you, so just bear with me a little bit. And I just wanted to tell you a little bit about Unique in case you didn't know. I think many of you are members already. If you're not a member, then please grab one of the Unique staff or trustees and we can join you up. Unique is a community of 30,000 families all over the world in more than 100 countries. And what we do is we try to provide support, information and a voice to all those affected by rare chromosome or gene disorders. I think if Unique staff and trustees can stand up and give a little wave. We've got a couple of our information officers here, Francesca and Anita, who if you ring the helpline or email the helpline, and they also sign up the new members, so they're here, so feel free to ask them any questions. Claire, who is our scientific communications officer, who's responsible for all those amazing condition-specific guides that are on our website. We've got Louise, who is our finance officer, who's actually just walking in the door, handily, and is outside selling Christmas cards, never too early for your Christmas cards, so recommend you get organised, and she's our finance officer. And in terms of trustees, we're really lucky to have a few here. Shweta, who actually I have to say a huge thank you to, is the person who's responsible for this event today. She introduced us to the Royal Society and made this day possible. Sophie, who's our chair of trustees over there, who lots of you may know already, has worked really hard with lots of enthusiasm for this day, so a big thank you to her. And Jill, who's also standing up, is our longest serving trustee here. She's been a Unique trustee for more than 30 years and actually is sadly stepping down tomorrow at our next board meeting. So we just want to take this opportunity to say a huge thank you to Jill. Unique would literally not be here today if it wasn't for Jill and all her hard work. So thank you. I just wanted to thank the RSM as well for hosting us today. I think it's going to be a really nice day. It's a great opportunity to learn some things, meet some other families, and hopefully make some friends. And, of course, buy your Christmas cards. That's the most important bit. And particularly Carleen and Charlotte, who've been responsible for organising us and doing all the logistics and registering you and everything. And I think that's it. One more thing that I'd just like to say is that Unique staff and trustees are going to go and have lunch and a cup of tea in John Lewis, which is just around the corner after the event. So if you don't have to rush off, we'd love you to come and join us. So that is my Oscar speech of thank yous over now. And I'm going to pass on to Professor Eamon Sheridan, who is a clinical geneticist and has been a clinical geneticist for many years, and is now on secondment with the genomics unit of NHS England. So he is going to properly open today's meeting. So thank you.
So thanks very much. So I'm here. Sarah actually asked Sue Hill, who's the kind of chief of genomics in the UK, to open this meeting, but she's in Japan, so you get me instead. I'm the kind of supply Sue. And I've been a clinical geneticist, as Sarah said, for a very long time, and I have used and abused the Unique resource throughout my entire career. So this is a real terrific opportunity for me to say thank you and to emphasise what a fantastic organisation this is. I'm hoping this is going to move the slides on, because otherwise I'm a bit stuck. So you've got a terrific day ahead of you with lots of fantastic talks and opportunities to speak to people. And looking at the agenda, there's an opportunity to actually discuss things that actually people like me, clinical geneticists, and other high-powered doctors are often not really interested in. So sleep disorders, we're rubbish at. We don't help you with that at all. But you've got an opportunity today to hear experts talk about that. Behaviour we're often not interested in. Again, you've got opportunity to hear about that. And absolutely key, the mental health of individuals, families and relatives of children and adults with these disorders is so important and is so often ignored. And again, you've got somebody who's going to talk to you about that today. So I think that's fantastic. As I say, I have used and abused this organisation for many a long year, and it's a real opportunity for me to come and say thanks. You are a community. As Sarah said, there are over 30,000 families who are part of this community, and I've been there at the time when many children have had diagnoses for the first time, and the sense of isolation and loss that is a consequence of that is so obvious when I'm there in clinic. And what Unique does is it actually allows you to form a community together which says you're not alone, that there are other people who will understand what's happening to you and who will be able to help you. And I think that that is fantastically important. As I've said, I've pinched lots of these pictures from the Unique Facebook site. One of the things that Unique does is provide information. And I have used the information leaflets over many years. But one of the really key things that it does is it provides strategies for families and individuals to kind of get through over the longer period and get through the day. And sometimes just get through the school holidays. Okay, so somebody who's got normally functioning children, getting through the school holidays was pretty hard. If you've got kids with problems, it's just a major issue. And what Unique does is it provides an opportunity for individuals who are part of the community to both benefit from the advice of other people in the community and contribute to it. Again, combating this sense of isolation, which is so often a problem in these areas. You do provide a vast range of information leaflets. Some of them are really, really good and are really helpful to me, but a lot of them are really, really good and way more helpful to you because they refer to these kind of issues that, as I say, doctors often don't pay much attention to. Critically, you have one which warns you about what might happen when you come and see somebody like me for a clinical genetics appointment. And this is my colleague Mark Tishkovitz, who very kindly agreed to be in this picture at the end. He's far better looking than me, which is why they asked Mark and not me to be in this picture. But as I say, crucially, these things that doctors are so rarely interested in, how to look after teeth, sleep problems, legal advocacy. These are issues which are so important. And they, again, as I say, provide you with this community of support, which means that actually, as a parent of one of these children, you don't have to either despair or spend your entire time being a stroppy parent, dealing with schools and with social services, because that's absolutely exhausting. As a community, you're able to provide support to each other, which does this, and it's so important. This is just a letter from somebody that's on the website saying how important all of this was. As a family, the diagnosis was so scary, but due to the support, we feel informed, prepared as possible and positive about the future. And thank you for providing this. It's utterly critical. I was a professor, so I did lots of research. One of the things that you do, one of the things that your community does is give people like me access to people like you for me to be able to say, please contribute to my research, because all of my research was dependent upon the cooperation of families and children and adults with these rare disorders, and so that made my academic career and allowed me to follow a career where I was able to organise my life entirely to my own satisfaction, and probably to nobody else's. So I've got a huge thank you to say to you for that, because it was fantastically useful, and contributing to research is really, really important. But what you do is provide this power of knowledge. This again comes from the Facebook page, and this is so important. It allows individuals information, and it allows people to find out that there are lots of different ways of skinning the same cat. So this community actually allows you to support each other and to provide individuals with the multitude of strategies to deal with the same problem. So the problems often won't go away, but if you can be provided with half a dozen or several dozen different strategies to deal with exactly the same problem, where you can, if nothing else, you can cycle through them, and that, again, as I say, helps you to get through and helps you to help yourselves and to help other individuals in the community. There's as I say, heaps of guide on the website, 190 rare chromosome disorder guides. This was of July 2021, and the numbers have gone up since then. 61 single gene disorders, and I've contributed to a couple of those themselves. Lots of translations, and as I say, huge numbers of practical guides. And this paragraph at the bottom, I thought was so key, that the insights and experiences that parents share about their children of all ages are of help and reassurance to other parents, as well as to clinicians like me. Massively important to clinicians like me, but much more importantly to individuals like yourselves, particularly with these areas of behaviour and education and social issues, which actually people like me are completely hopeless at. I don't really help with any of that at all. It's you as a community who are able to do that, and you as a community who have informed me about what I need to do. So I've had heaps of parents who've come along and said, this is the unique leaflet on schooling. Do you think you could possibly write to the school and say some of this? It's so valuable and so helpful, because I don't really know what to say, but fortunately now I do. So as I say, all I really wanted to say was you've got a great day ahead of you, lots of really interesting stuff. But for me, as a clinician, all I wanted to say was thank you, because what you've achieved over many years as a community is fantastically valuable. So as I say, thank you. I hope you have a great day.
So I'm just going to introduce Hayley. Hayley's going to talk to you about her work looking after kids like your kids who have challenging behaviour, and she's been doing this for a long time.
I give my age away.
And so she's going to give a talk, and then there'll be time for questions. So please feel free to kind of think up your questions as she goes along. And again, it's really informal, so just put up your hand if you have a question or you want any clarifications. So
everything else on the fourth floor.
Yes. Yes. Everything else. If you
wish to go to
want to be anywhere else. Thank you, Hayley.
Thank you. Hi. Hi, I'm Hayley. I'm really grateful to be here today. That was a really inspiring session that we just had. So thank you for inviting me to come and speak. I'm going to talk about behaviour. That is evident from the title. I am an associate professor at Warwick Medical School. I'm 32 weeks pregnant. I've got like a head in my ribs somewhere, so bear with me if I get a bit breathless. So I'm also one of 4 co-directors of the Cerebra Network. You may or may not have heard about the Cerebra Network. We've got some nods, that's great. So I realised I didn't actually put any of this in my slides, so I will just briefly explain what the Cerebra Network is. Way back in, it was like between 2008 and 2020, Professor Chris Oliver, some of you may have heard of him, ran the Cerebra Centre at the University of Birmingham. And then in 2020, he sort of slowed down, moved towards retirement, and we had this natural expansion to the Cerebra Network. So there's 4 of us that were trained under Chris's supervision, and we then each got posts at different universities, but we really wanted to carry on the work that we'd been doing for the last many, many years, because it's so important to us. So we set up the Cerebra Network. So we're now based across 4 institutions. That's Warwick, Birmingham, Surrey and Aston. And we each lead a team of researchers. So this expansion has just meant that we just have loads more people now to be able to train and upskill the next generation of researchers and clinicians working with people with rare and complex needs. So that is sort of an overview of where we come from. And a really big part of this work that we do is around behaviour. We know that it's one of the sort of the things that families talk to us about the most, the things that it concerns them. There's not as much support. There's a higher need for improved assessment and intervention when it comes to behaviour compared to some other things. So we've spent a few years now working on a way in which to improve that assessment and that intervention. We're sort of in the middle of a research project doing that. So I'm going to share a little bit about that project with you today, but also hopefully give you some useful tools and resources that we have developed along the way. So the whole premise of this tool that I'm going to talk about is a checklist. The reason we have developed this checklist is because we know that there is a high prevalence of behaviours of concern. We're calling it various different things. Behaviours of concern is something that we know some parents have got a preference for. Behaviours that challenging behaviour. We're talking about the same things. If we're being really detailed, we might be thinking about self-injurious behaviour, behaviour directed towards other people, so aggression, hitting, kicking. But honestly, even speaking to parents about some other behaviours that concern them, that is just as important as these other behaviours that may or may not fall under that banner of self-injurious behaviour or aggressive behaviour. It might be something completely different. If it concerns the parent or the person, then that is something we want to be considering and looking at. So I'm going to probably call it different things, but we'll go with behaviours of concern. So we know there's a high prevalence of these behaviours in children with intellectual disability and complex needs. What we quite often hear from parents is that they don't know where to begin or where to start with asking the right questions or what questions to ask when they see a professional. We also know from the professional side of things quite often people with that present in clinical services with behaviours of concern, it is the behaviours that are focused on. So people might go down a behaviour pathway to have a look at what can be done just to look at behaviour in isolation. But we know from a wealth of research now that there's a number of things that actually cause that behaviour, and quite often those things are missed or they're neglected in this population probably because they're hard to assess. It's difficult to actually know what is going on some of the time, so it often gets missed. And the purpose of the checklist is to try and avoid those things getting missed. So we call that diagnostic overshadowing that we're trying to reduce the likelihood of. So diagnostic overshadowing, for those that aren't aware, is, you'll be aware because you will have experienced it when you go to a clinical service and they say, or you might say, I think I'd like to talk about this. Oh, that's just part of the syndrome. And that's what we want to try to overcome, is that actually it's intellectual disability or these syndromes are an explanation. They're not necessarily a catch-all, therefore we can't do anything about it because of this syndrome. It's just part of it. There's lots of things we can do, and so that's why we want to use this checklist to try to reduce that. So you can see this is one version of the checklist. This is the Be Well checklist. Chris Oliver led on this with a huge team of people, and we put together this checklist with all of these different causes of behaviours of concern. And this was based on research as well as clinical expertise within the team. You can download this directly from the Cerebra website. So Cerebra, the charity, provide our core infrastructure funding. So we work with them to produce this guide as well as a number of others. So if you just Google Cerebra parent guides, there's a tab that says something like emotional and mental health or something like that. And you will see the Be Well checklist alongside a whole host of other guides that we've produced as well. And I'll show you what we have done across all of these slides. And this is a little bit of what it looks like. This version, the Be Well checklist that is available on the Cerebra website, is quite a meaty document. We're in the process of trimming it down. But the first thing, after getting through all of the instructions, which is a lot, the first thing that we would suggest is that people actually document what the behaviour of concern is in as much detail as you possibly can, and then rate the frequency of that and the response. And there's sort of guidance on how to actually do that on a scale of like 1 to 5 and what each one would mean. And it gives you a good starting point of what you actually want to focus on, because quite often when there's a number of behaviours that are of concern, they might actually have different causes. So it's better to sort of be really specific. You can fill it in as many times as you want. If there's like 20 behaviours of concern, you could fill it in 20 times. But it's better to just be really specific about a behaviour because it might be caused by something different than a different behaviour. Then we have a list of items. The items that we have come up with, we have done so because we know they have a direct or an indirect influence on behaviour and, importantly, on people's well-being. But they are in addition to factors that are important for everyone. So this is not a checklist that says, have you done your exercise today? Have you practiced mindfulness? Have you done this, that, and the other that we know is good for everybody? These are things that are over and above that, specific to the population that we work with for people with rare and complex needs, and those in that sort of moderate to profound intellectual disability range. Importantly, there are also things that can be changed or accommodated. So there are, treatments out there, or there's things that can be done in the environment that can accommodate these things. So we're not, again, it's not just a list of things that we're like, yes, that might be causing it and there's nothing you can do about it. There are things that can be done about these specific things in the checklist. That's why we wanted to include them. And finally, there are things that are often missed or neglected in clinical practice because they're hard to understand. So that's why we wanted to produce this, so that there is a systematic way to actually go through these things. And these are the items in the Be Well checklist. They've changed slightly now, but I'll talk about that later. I'm going to go through each of these and tell you why they are in the checklist as it stands. But there is also a reason that pain and discomfort is at the top, because that, we know, is missed. And it's actually really, in many cases, very, very simple to treat if you identify what the cause is. And there's ways to do that. So that's at the top of our list. And then I'll go through each of them individually. But essentially, each of the items, there is space that sort of gives you some signs to look out for if you're not quite sure if the person you care for is in pain or discomfort. There's things you can look out for. So we list those, and then you can rate them in terms of how much of a concern is this to you, or how much do you see signs of this. So from 1, no signs of this at all, right up to 4, definitely see signs of this, and this is a significant concern. So that then gives you, once you've filled it in once, it gives you a starting point for various different things, all these different causes of behaviour. What is the current picture right now? And then the idea is that you would take that to your healthcare professional, clinician, anyone you're working with, school, and I will also guide you to things that are in some resources that we've produced that help with these sorts of things. And the idea, hopefully, is that over time you would fill it in again and again, and hopefully there would be some changes. So I'm just going to go through each of the items and tell you why they're there, essentially. So with pain and discomfort, this is the most important one. This is such a huge cause of behaviours of concern if someone is in pain or discomfort and they can't tell you. So I'm going to just whiz through some of the research behind this as to how we know this impacts behaviour, not even thinking about children that have rare and complex needs or intellectual disability, but 15% of all children bang their head between the ages of 1 and 4 years. 50% of those have a middle ear infection. It's really painful. At that age, can't really tell you. And so once that gets treated, we know the head banging stops. In people with rare and complex needs, this is research. It's a small table, so I'll point out the important things. This is research led by Lucy Wilde, who was working in the Cerebral Centre at the time. And this shows a list of health conditions. This is for people with tuberous sclerosis complex. And it shows those that do and do not show self-injurious behaviour, and those that do and do not show aggressive behaviour. And the important thing to just note from this, this table here is that for self-injury, those that do show self-injurious behaviour were much more likely to have gastrointestinal problems than those that do not. And again, we know from our clinical experience, reflux is sky high in people with many different rare genetic syndromes. When that reflux is treated, the behaviour comes right down, and reflux is actually very, very easy to treat. With aggression, it was actually different. This is a useful point to think about these behaviours individually, as I said earlier, rather than lumping a behaviour together, behaviours of concern together. Actually, when we're looking at aggression, we see something very different. It's actually skin problems that are sort of that contributing factor to aggression. So skin picking, eczema, things like that. Again, very easy to treat, but those with irritating skin conditions are more likely to show aggression than those without. So again, creams, things like that, things that can be treated but often just go missed because it's too simple. So mentioned reflux already. This is just a graph from people with Cornelia de Lange syndrome. You can just see here, so GRQ score, that's just how, that's a questionnaire that tells us how likely it is people showing these signs of gastrointestinal reflux. And you can see the score is much higher in people that show self-injury compared to those that don't. We also see in autistic children with intellectual disability. This is just a small snippet of a graph. This is a paper by Caroline Richards, who's one of the other co-directors. Health problems. Autistic children with health problems are 1.5 times more likely to show severe self-injury compared to those without health problems. And then this table is work led by Kate Eden. So the measure she used here was, it's the non-communicating child pain checklist revised, or NCCPCR for short. And this is a questionnaire that parents complete that indicates how likely it is somebody is experiencing pain. And you can see here, so the score was 26 for people that did show self-injury and 9 for those that didn't show self-injury. So those that are showing self-injury are more likely to be in pain. And the same for aggression. So for those that do show aggression, 20. For those that don't show aggression is 7. So there's a huge difference in those scores that indicate whether someone's in pain or not. So that bottom line with pain and discomfort is that people that show behaviours of concern, often one of the causes of that is that they're in pain or they're in discomfort. You might be thinking, why? Why does that contribute to behaviour? There's a number of different theories around the mechanisms behind that. One of them actually is quite practical. The behaviour actually attempts to remove the painful stimulus. So with reflux, for example, if one of the behaviours of concern is someone putting their fingers down their throat, that might actually be a direct response to reflux. The other thing is pain gating, which you may have heard of, where the behaviour blocks the transmission of other painful stimuli. So the best way to think of this is if, like when you bang your funny bone on a door, and you like rub it like that really hard, it's probably actually not helpful at all, but it blocks that transmission of that painful stimulus, and it's your automatic response is to sort of almost hurt yourself even more to block it, and so that's what pain gating is. So that's one theory as to why that contributes to behaviour as well. The final sort of mechanism that may be implicated is that behaviour is subjected to social reward. So when a behaviour is present, rightly so, a parent, carer, teacher, anyone would intervene if someone is unsafe, but that then may produce a social reward of having attention, that sort of thing. So we'll go through that at the end as well, because that's one of the items. So there's that interaction with the behaviour becoming learned, it then sort of satisfies a need of having attention. So the things to sort of look out for, I think, when it comes to pain and discomfort, first of all, is a change from baseline. So you know what your child or the person you care for typically would show in terms of their behaviours. When you, or if you, see a change from baseline in that, then that might indicate the emergence of a health condition that is worth monitoring, looking out for. The intervention in this case is really simple. It's nothing to do with behaviour. The intervention is the treatment for the painful health condition. Parents have reported to us a lack of acknowledgement, reluctance to refer from specialists. People are smiling. You've experienced this, I'm sure. We have research. We have also this guide for parents, which is again available on the Cerebral website. This just goes through what sort of things might indicate that somebody is in pain, and what you might be able to do about it. So it is hard, I think, to get healthcare professionals sometimes to acknowledge that someone might be experiencing pain and to move sort of beyond the behaviour and the syndrome and the intellectual disability and just think, could this be something simple? So any nudging from parents in that direction is always useful. And that's the point of the checklist as well. The rest of the items I'm a bit quicker to explain. That one's just a really important one. So the second item is sensory impairment or sensitivity. So we've got sort of like 3 options with this. Hypo-responsive, where someone is under-responsive to sensory stimuli. Hyper-responsive, over-responsive, or sensory seeking. This graph here, this is work led by Mary Heald from the team as well. Essentially, this graph is to just show that we see different profiles of these types of things in people with different rare genetic syndromes. So a particular syndrome might be associated with under-responsiveness. Another one might be associated with hyper-responsiveness. The way that this actually relates to behaviour is important for determining what that profile is. So those that are under-responsive, essentially, it may be seen that they have a higher pain threshold. So that has then implications for particular behaviours of concern, like things to do with scalding water, being able to put your hand in, scalding water to get something out, that sort of thing might be a behaviour of concern. It might indicate that somebody is under-responsive to that sensory input. Over-responsiveness is more, the way that links to behaviour is more to do with the emotional reaction that triggers, because it's actually just really unpleasant to be in an environment where there's a lot of sensory input if actually you're oversensitive to sensory input yourself. And again, that can become learned, because if, say, for example, somebody who is hyper-responsive to sensory input goes to a supermarket where there's a lot of noise and it's really bright, it's actually really unpleasant. They show a behaviour, they get removed from that situation, and then that becomes learned, that behaviour means they get out of that situation that is actually unpleasant for them. And then sensory seeking is a little bit different, and the behaviours we would see associated with that are more like the eye pressing and eye rubbing to sort of generate the spots that you do when you sort of pull a funny face, like sort of squint, and close your eyes really tightly, and then you open them and you get like the stars. That sort of thing is sensory seeking, get the same effect from rubbing your eyes, poking your eyes, that sort of thing. So quite often those are behaviours of concern that we hear about, and that's probably more related to sensory seeking. Again, you'll see a theme here. We have a guide on sensory processing available on the Cerebra website, where you can get more information about what this looks like in people with intellectual disability, and certain things that might be helpful. Okay, the third item is anxiety or low mood. Those are 2 very different things. We've now since separated those things in a new version of the checklist, which isn't out just yet, but anxiety or low mood. So I'm going to focus on anxiety because it's easier to explain how that links to behaviour. I think it's also more common. The reason that this is an item in the checklist is because of the prevalence of anxiety in people with intellectual disability and rare and complex needs. My colleague Jane is doing a talk on mental health at the moment, all around anxiety. I'm going to touch on it very briefly. But essentially, in some rare genetic syndromes, the prevalence of anxiety is actually as high as 80%. We've done some research using clinical interviews in people with Cornelia de Lange syndrome. Actually, we saw 98% of people showed symptoms associated with anxiety. Like, the prevalence is just huge. It's also relatively new that this is actually, in research world, that people have even thought people with intellectual disability can experience anxiety. So the research is in its infancy, but we're getting there. We know now that it's really important to look at. So this was the study I mentioned, the clinical interview. This is my PhD student, Laura Groves, who did this clinical interview, and actually you can just see the high prevalence of different types of anxiety disorder. So the sort of grey bar at the top shows threshold. That's people that would meet a clinical diagnosis for anxiety on those various different things. Sub-threshold is showing symptoms, but not quite enough to trigger a diagnosis. But there's issues with that anyway, because the diagnostic process is not set up for people with an intellectual disability. So that's why we wanted to look at both of those. And then it's the blue bar that we see the prevalence of it not really being present. So social anxiety for this group was particularly high. And yeah, not one person in this study had a diagnosis of anxiety. Therefore, they didn't have the support that comes with a diagnosis of anxiety. So sort of being mindful of that, I think, is really important when we think about it, how it might relate to behaviour as well. In terms of mechanisms, this was a study that we published just earlier this year. This is the mean cortisol level in people with Cornelia de Lange syndrome and Fragile X syndrome compared to neurotypical children. So there's quite a bit known about cortisol in Fragile X, but this was the first time we'd done this in Cornelia de Lange syndrome. Two groups that show really high rates of anxiety, two groups that also have sky-high levels of baseline cortisol. So that indicates what the mechanism is behind this huge prevalence of anxiety. It's biological, or there's at least a biological component. So how does this relate to... Yeah, go ahead. Yes.
Is the white one
Neurotypical children. Yeah, sorry, I haven't labelled these at all. Yeah, and then the other two are the two different syndrome groups. So how does it relate to behaviour? So I just want to walk you through this cycle of anxiety avoidance, we call it. If we start with a situation, a parent walks a child to the park where there might be dogs. This is a child with a dog phobia. And then the child experiences anxiety, so their heart rate increases, they feel tense, they feel worried. The critical thing here, that child engages in any behaviour to escape any dogs. So that might be as simple as just pulling their parent away, or it might be much more complex. It might be throwing themselves on the floor, it might be hitting, it might be biting, anything. They will basically do anything to get out of that situation because they're really anxious. Oftentimes then that would lead to being removed from that situation. The child experiences short-term relief. The parent, carer, whoever is with them also experiences that short-term relief. In the long term, though, that anxiety increases because there is a loss of confidence of coping. No one is sort of experiencing this, I can do this, I can cope with this situation, nothing bad happened, providing nothing bad happened. There's a lot of stuff in the news about dogs at the moment. But that means then they're also more likely to use those behaviours. That's how it interacts with that learned behaviour that we'll come back to at the end as well. So I think hopefully you can see there how anxiety in itself then relates to behaviours of concern. And again, we have a guide on anxiety. We're particularly proud of this one. It was highly commended by the British Medical Association a few years ago. And we've just reviewed it. So this one is very up to date. Again, available on the Cerebral website. It's broken down into 3 stages, the signs of anxiety, what it looks like in people with intellectual disability, and what sorts of things you can do about it. Okay, number 4, sleep, which I'm about to have very little of, I think. So sleep problems we know in this population are very common. We also know they shouldn't be accepted necessarily as part of intellectual disability. This just comes back to that diagnostic overshadowing. If someone has told you that a sleep problem, your child's got a sleep problem because they have this syndrome, because they have intellectual disability, it's not an explanation. There is a sleep problem that needs addressing. Data to show us how common this is from Andy Surtees here, who did a meta-analysis which is where you sort of pool all the research that exists and have a look and do something really fancy with statistics. These are different. The black bars are different rare genetic syndromes. The white bars are controls. The lines shows the percentage of any one group with a sleep problem. So AS, I believe, is Angelman syndrome. Sky high compared to controls. Again, a different study showing the same thing. Intellectual disability, much higher than controls. Intellectual disability, Prader-Willi syndrome, autism and Down syndrome, all much higher than controls in terms of the prevalence of sleep problems. So we know they're common. We also know that sleep problems themselves have, like behaviour, they have causes. Quite often, pain is a cause of sleep problems, so that reflux again. Reflux is much more painful when you're lying down. also, any type of painful health condition, croup is more painful when you're lying down, asthma is more difficult when you're lying down. So that's how those things can contribute to sleep problems. The other thing that can contribute to sleep problems is anxiety. I'm sure you've all experienced this as parents of children with rare and complex needs. It's hard to fall asleep when you're anxious. You wake up early, you wake up a lot. It's hard to get back to sleep. The other thing for this population is that, again, these are linked to learned behaviours in terms of parents going into the room because their child's not settling. Those things trigger a cycle of learned behaviour. You know, if I'm doing this, then someone will come and see me and I'm not alone in my room at night when it's dark. How we know these are some of the causes. This is, again, work by Caroline Richards' team at Birmingham. They lead a really great programme of research on sleep. This shows when people fall asleep here. This is a sleep onset. These red dots show high prevalence of behaviours that indicate someone's in pain. So in this graph here, it's leg movements. So a lot of leg movements in bed at night can indicate that someone's in pain. And you can see here, this 20 minutes before the person falls asleep, there's like a high prevalence of painful behaviours here. And then it drops off. These yellow bars show where it's actually much lower prevalence of pain behaviours. And those happen right before the person falls asleep. So it shows that sort of trajectory of, I'm in pain, I'm in pain, I'm in pain, can't sleep. The pain then reduces, and it's only when it's reduced that that person then can actually fall asleep. We know, in terms of how it's linked to behaviours of concern, we all know that when you've had a rough night's sleep, you're more irritable the next day. It just doesn't help with emotion regulation. You're more irritable. That is the case for everybody. So it's, of course, the case as well for children with rare and complex needs. We have a sleep guide on the Cerebra website. So this, again, has lots of tips about how to promote the best sleep that you can for your children and the people you care for. The fifth item, emotional regulation. We've actually ended up dropping this one, so this is a funny one to talk about because it no longer exists in the Be Well checklist at the moment. But this is essentially someone's ability to control extreme emotions. It's often described as coming out of the blue. And it's also described as something that happens to somebody, so it indicates they're not actually in control of that. And some research that has been conducted quite a while ago in our team now shows this pattern of the sort of behaviour, the explosion, as it were, of this emotion dysregulation happening to somebody, coming out of the blue. The trajectory then goes down. When that person is calm, they're often very remorseful, very sorry for what has happened, and that again points to a lack of control, and that this is happening to someone. I don't need to explain how that is related to behaviour because it's all tied up in the same thing. That behaviour is that emotion dysregulation. We have a guide on it. Emotional outbursts. So again, some descriptions of emotional outbursts, what can be done about it. So hopefully, if that relates to you, that guide will be useful. Okay, the sixth item. This is impulsivity and insistence on sameness. Again, these are two very different things, and we've since split these. But this essentially describes cognitive difference over and above intellectual disability. So it's something on top of that. It's different. So impulsivity is finding it very difficult not to act immediately, and finding it very difficult to wait. So we kind of think about it as putting the brakes on behaviour. It's not possible in people that are very impulsive. And then insistence on sameness is a particular adherence to routine, wanting the routine to be the same over and over again. And that is linked to attention switching. That's why we say it's a cognitive difference over and above intellectual disability. It indicates that someone finds it difficult to switch attention from this routine to a different routine. And that then can trigger behaviours of concern. So I'm going to show you a few graphs now as to how we know this contributes to behaviours of concern. this is all longitudinal data. So because we've been collecting data over a number of years now, through something that is now called the Beyond study. I've noticed in the session before there were a couple of parents that talked about syndromes that are actually included in the Beyond study. So that's exciting that is open. That's open at the moment. But this is data on autistic children across a 3-year period, and it shows higher levels of impulsivity, so persistent self-injurious behaviour. So people over a 3-year period who did not ever stop showing self-injurious behaviour, that's our persistent self-injury group. That's the line, the bar on the right, compared to those who have never showed self-injury in that 3-year period. Impulsivity was much higher in those that have persistent self-injurious behaviour than those that have never showed it. And then we saw exactly the same at a 10-year follow-up. So the persistent self-injury group essentially showed self-injurious behaviour across a 10-year period that didn't drop off. The absent group had never showed it across that 10 years at all. And you can see it's even more different in terms of where those bars sit. The impulsivity is much higher in that persistent self-injury group. And then this is people with Fragile X syndrome. Again, we just see exactly the same. This is over an 8-year period. We actually see here the absent, these graphs are switched because, different authors do different things. This is our persistent group who showed self-injurious behaviour over the 8-year period. This is the absent group. It's actually here, repetitive behaviour. So that's that adherence to routine. The repetitive behaviour that is that difference there between those groups. With aggressive behaviour, it was the impulsivity. So again, that's why it's important to break down those behaviours and be really specific, because we actually see different things contributing to that, different risk markers. So what I think was more concerning about this research that I've not even put up is that in these groups, like the persistent self-injury, without intervention, self-injury persisted for like 76% of the sample. Like, it's not something that will necessarily go away if you just wait. It needs intervention. We have a guide on cognitive differences. So this is all to do with the inflexibility, that, adherence to routine and impulsivity as well. So have a look for that if this is something that relates to you. And then our 7th item, social behaviour. We've talked already a bit about anxiety. So for this one, it's particularly social anxiety we would be thinking is important to consider. But actually, there's another side of social behaviour that is not the sort of withdrawal or anxiety response. It's actually social motivation. Many people with different rare genetic syndromes are incredibly motivated to be sociable, to interact. It's part of what we've heard earlier from parents. I think of, this really funny nature, wanting to, speak to the bus driver all the time, that sort of thing. I didn't have any graphs to put up for this one. So, there are graphs that exist, but it's nice to have a quote instead. So this is a teacher of a child with Smith-Magenis syndrome who said, if I could provide constant, unwavering, one-to-one attention to this child throughout the day, she might never have another tantrum. And that just shows how the social motivation is linked to behaviour. It is those sort of behaviours that generate that attention, that response, that then drives it. So that's how it's linked to behaviour. So those 7 items in the Be Well checklist are all what we would consider internal characteristics. First of all, I think they show us how difficult day-to-day life can be for somebody with rare and complex needs and intellectual disability, sort of having lots of these, not all of these things apply to everybody, but many of these different things to consider. But they're internal characteristics. They are to do with an individual. They vary across individuals. There are a couple of items then at the end that are sort of catch-all, cover most people, regardless of what those internal characteristics are for any one person. So the first one of those is learned behaviour. The premise here is just that behaviours can be learned. There's lots of research showing this. And the way I'm going to break it, this is such a simple way of describing it, but in the interest of time, that's what I'm going for. So there's two different ways that can happen. There can be two motivators. Someone can need someone or need something. They then engage in a behaviour, in this case, face slapping, so self-injurious behaviour. Someone then rightly intervenes because they need to keep that person safe. And essentially what happens is that need is satisfied because they needed someone right back at the beginning. The behaviour happened and then the need is satisfied. The other mechanism is that they need something to stop. So person with rare and complex needs something to stop. They may be in a situation that they're not enjoying, being asked to do something they don't want to do. The behaviour then might be hitting out, aggressive behaviour. That thing stops because people are not going to keep putting that demand on an individual who is hitting out, and that need is then satisfied. There's also a sort of mutual reinforcement cycle in that as a parent or carer, the need is satisfied for you as well because the behaviour stops. But essentially what we know is that then means the behaviour is learned and can be more likely to happen again in the future because it's satisfied that need. So yeah, essentially the person learns that behaviour is a function for satisfying that particular need. It interacts with the other characteristics. So I've mentioned particular cases where that is the case, but essentially those internal characteristics can increase the motivation for the behaviour cycle, the learning cycle to start, essentially. And then the ninth, so yeah, there is information in the Be Well checklist about learned behaviours. It's like the one that I haven't put a guide up about. I don't think we've got one. There is information about it in the Be Well checklist if you need more information about that component. And then the final item is communication. So we know, obviously, many people with intellectual disability, rare and complex needs, have difficulty communicating verbally. There are essentially, I think 8 things that we would consider as a bare minimum that people need to be able to communicate in one form or another. It does not have to be verbal. And those are that they want something to start, want something to stop, they want social contact, food, drink, an activity or an object, help, or to go somewhere. Those are considered like the 9 basic things that are ideal for someone to be able to communicate. The way that you actually rate this in the checklist is a little bit different to the other items where you're saying like there's no sign of this or there's lots of signs of this. This one is more for each of those things, can they communicate this all of the time or very nearly all of the time, or can they not communicate that at all, or it's very hit and miss? The way that relates to behaviour is actually really simple. There's no graphs for this one either. Behaviour is a form of communication, and we know from, the learned behaviour that is essentially what happens is that is a way of communicating what an individual needs or wants. There is a guide for that one. So, yes, communication with children with severe or profound intellectual disability. So if communication is something that your child or the person you care for finds difficult, then that guide might be useful. So, how do we use the Be Well checklist? How am I doing for time? We're nearly there.
We've got 15 minutes, including questions.
Okay, fab. So we would say with the checklist, we would use it, or we would encourage people to use it. You could use it, first of all, when there's a particular concern about behaviour or well-being. You could use it to look ahead to ensure future well-being is as good as it can be. You may wish to consider using it during regular reviews. So we've heard a lot today about the EHCP process, but could also be annual health checks with the GP, any paediatric meetings, clinics, anything. You could take the checklist to the healthcare professional and use it. The idea is that it's a way to structure conversation with that healthcare professional about the things that you are concerned about that you've identified from the checklist. We would typically say that items rated 3, 4 or not sure could be underlying causes of behaviour or poor well-being. and that those things probably need some attention. So I'm now just going to spend a few minutes explaining where we've sort of gone with the checklist project, sort of what's happening now. This is actually what it looks like now. It's a little bit different. We've dropped the Be Well checklist. It's now the behaviour checklist. The aims of this project, this was funded by Great Ormond Street Hospital Charity. The aims of this was to revise the Be Well checklist, which was all based on research, very robust, valid research, but it didn't have the voices of parents and it didn't have the voices of clinicians in the development of it. So what we wanted to do with this project is bring parents on board, bring paediatricians, clinical psychologists, lots of other professions on board to help us actually revise the checklist so we know that it's as useful as it can be to the people that are actually going to be using it, not just academics.
I was sent it as a trial to write a comment on it.
Were you?
The Be Well.
Oh, the Be Well checklist.
Yeah, they sent it to, I don't know, like really early on. I can't remember if it came from Cerebral.
Cerebral.
I think it might have come from us.
Might. Yes.
Chris Oliver gave the talk,
And then,
and then we surveyed the families who came to the talk.
Okay, that makes sense. Okay, that makes a lot of sense. So it's got some family input, which is good to know. With this project, we've done it from a point of view of getting the parents involved in we've created a checklist development group, which includes parents and clinicians, to sort of go through each element of the checklist and pull it apart and put it back together again. So we're also at the moment testing the feasibility and acceptability of the checklist being used in paediatric clinical services in special schools. The aim has changed throughout this process. We now sort of see it as a tool to structure conversations between the parents and carers and the professionals to promote sort of shared language. But we also want to make sure that it streamlines referrals. If a sleep problem is identified in the checklist, we want to be able to see that the checklist flags sleep problems. It then flags it to the healthcare professional who might put someone on a sleep service referral or prescribe melatonin or do something about sleep so it's not just left. So the way we're doing that, as I said, is we're co-producing the checklist now. That's across a couple of different phases. The first one was developing that group that helped us to revise it. The second phase was consultation meetings with two different groups of people, the parents and the professionals. And again, it led to lots of revisions. So that's what it looks like now. It's not actually available yet because we need to wait until next year, I believe. But it's much shorter. There's no sort of 20-page introduction anymore. And it's much more simple, I hope, to be able to complete. So unfortunately, you do have the long version still available to you, but this will come next year. And then it does have signs to look out for, how to score each of those items, and importantly, the link to the Cerebral guide that is associated to that item. That was missing from the first version as well, that one parent actually really helpfully said it would be useful to have some resources in this, not just being able to fill it out. The items are slightly different. Actually, everyone thought that the items were pretty good at representing the causes of behaviour, but we did, as I say, split some things that are actually very different, like anxiety and low mood, impulsivity and insistence on sameness. So a couple of things changed there. And then we're now in the process, so we've developed the checklist. We're now in the process of collecting data on its use in paediatric clinical services to test out how reliable it is, whether it's feasible for paediatricians to use with parents, how acceptable they find it. So we're just collecting that data at the moment. We're doing that through special schools, through parents who are recruited through special schools and charities, so you might well hear from us asking you to take part, who complete the checklist as well as other measures to just check that the checklist is actually measuring those things we think it's measuring. And then they fill in a questionnaire about how feasible it was to use. We then have a group who are recruited via the NHS, and those are the people that are then taking it to their paediatrician appointment, their routine clinic appointment that happens every 6 months to a year. So this is a long project. And again, they're filling out that feasibility information so we can get information how useful it is. We're also recruiting the paediatricians themselves so that they can tell us what they think of the checklist. So I'm just going to leave some quotes to just... These are people that have said it's useful, essentially. So I wanted to share some of those with you because it's always nice, of how it can actually be helpful in terms of things, sort of when you go to an appointment, some of the things you'd maybe thought about talking about, you'd forgotten by the time you got there. And this hopefully helps to alleviate that. So that was a parent that said about that. Someone else said it was useful to use. And then someone else said it was useful because paediatricians or other healthcare professionals often need objective information, and that this checklist does provide that in terms of the scores. Healthcare professionals often like to see that. And then another parent here said it was useful to see what support you need, because sometimes you don't actually realise what you need. You don't realise that something might be an issue that actually could have something done about it. We then also got really positive feedback from clinicians, which was a relief. So nice level of explanation, more than a checklist in that it opens up the door to further assessment and referrals. And then it gave valid grounds for further exploration on different topics. So useful to send to families as well during the waiting times. That was something that was quite nice to hear as well, actually, because the waiting lists, we know, are long. So it's something that people can actually do proactively in the meantime. Final plug, we do actually need some people to help us figure out whether the checklist is useful or not. So there's some information here if any of this relates to you, and you're able to help us with this final stage of the research. Yeah, we need some people to fill in some questionnaires and speak to us about their experience of using it. So I'll leave that up there. But thank you very much. I'll take any questions.
Hello, everybody. I hadn't expected the lights to go down then, which feels very overexciting. So, hello, everyone. So, my name's Kim Winter, and I'm a psychotherapist by background. I'm also the CEO and clinical director of an organisation called Rare Minds, which I'm going to tell you a bit about in a moment. I also just want to apologise for my voice, which was not in existence yesterday. So I hope that you can all hear me okay. So I'm a little bit croaky, and I like to think it's a little bit more film starry as a result, but we'll see as we go on. So thank you all very much for staying and coming to this session. And I just wanted to acknowledge that in some ways it might be a session you've looked forward to coming to, thinking about your own emotional well-being and mental health. Or it might be something that felt a bit challenging and you weren't quite sure whether you wanted to do that. Some of you are sort of going, oh, okay, yes, that was me. Yes. Because it is actually quite difficult when you're parenting, particularly a child or a young person with a rare genetic condition, to take the focus off their well-being and put it onto your own. And I just want to reinforce, and really the whole presentation today is about saying how important that is. Because all of you here keep the show on the road in many ways in your families. And yet, as the title of this talk says, you are often last on the list in terms of your own needs or being able to really look after your own emotional well-being. And I do know how hard that is. And it's why you need people like me and people like Unique to come along and say, it is nevertheless so important, and let's try and have a conversation together today about you and your needs. It's also quite timely, I think, that it's last on the list of the agenda today, which I quite like. So it's the thing I'm hoping to leave you with, which is like, yes, must prioritise my own emotional well-being too. Okay, so this is a little bit of a presentation in two halves. I'm going to try and speak a bit to your experience. I think what was so powerful in the first session this morning was how you all shared so openly your experiences and challenges and ups and downs of living with or parenting when you have a rare genetic condition in your orbit, so to speak. And in the second part of the presentation, we're going to have a little bit of a talk to each other in between. I'm going to try and leave you with some really practical thoughts and ideas that are just really easy to implement in practice, because what I don't want you to do is go away from this presentation thinking, oh God, another thing to do, another thing, I've got to be looking after my own emotional well-being, when am I ever going to fit that in? So this is really straightforward, simple things that I hope you can take away with you. My other handy hint is you only need to take away one. Okay, so don't feel you have to remember all of them. If something sort of rings a bell for you, just take away that one. It's my first challenge of the day, to get this to move on properly. Yay. Okay, so just a little bit about Rare Minds. So Rare Minds set up because there was no non-profit or statutory organisation that attended and understood the needs of those impacted by rare genetic conditions. And this seemed to me to be a real oversight. I've been a psychotherapist for over nearly 30 years. And in all that time, I kept thinking, surely there will be some organisation that steps forward to support families with their mental health and well-being. Because we recognise that your needs weren't well understood in statutory services. And that's even assuming you could access them. Because as we heard this morning, getting support for your own emotional well-being or that of the young people that you look after is in of itself a really challenging task. So at Rare Minds, we're very much about service provision. So we work with patient organisations to provide couples and individual counselling, workshops and group programmes. And we do training and support for those who run small organisations, small charities. And we have a presence that is increasing in the rare disease world to influence policy and practice to keep mental health integrated and on the agenda for those living with complex rare genetic conditions. Because I think, as we heard in some of the sessions I was in this morning, mental health is always, again, last on the list. It's always a thing that gets knocked down the agenda. But we really feel that if you're supporting your young person, if you're supporting yourselves, and if services are supporting you, that makes everything else that much easier too. So I'm really delighted to be here, and thank you to Unique for inviting me to come along. So I'm not telling you anything you do not know here. Living with a rare condition is emotionally challenging and can at times be very stressful. Many of you here, though not all of you, will have had perhaps a lengthy or traumatic diagnostic process. You might have ended up going around many different healthcare professionals. You might have had your experiences disbelieved. You might have been told you were an over-anxious parent. You might have been sent down all sorts of dead ends. And one of the consequences of this is that it's likely your trust in healthcare services and systems will be lower. That makes sense, right? But that trust in and of itself can impact on your emotional well-being, because when we are struggling, we all want to feel safe and understood and attended to by services that should be there to help us, right? We often talk about a kind of loss of innocence when you're diagnosed with a rare genetic condition. We all grow up with the idea that doctors and nurses are there to help us and make us better. And when you're living with a rare condition, often you're coming up against the limitations of services and systems and individuals. And that in and of itself can be really disappointing and leave you feeling a little bit less safe in the world in certain ways. There's often complex interacting and emotional and physical symptoms. I'm sure all of you here have sort of sat down either with yourselves or with your child and thought, is this a rare condition thing? Is this just cheese? Is this a kind of like, how do I understand this? Is this their age? How do you make sense of what's happening to your young person, your child, particularly when things can change and fluctuate? How do you make sense? You're having to do a lot of cognitive work all the time to keep on top of understanding what's happening. And all of you are managing multiple uncertainties. And multiple uncertainties is something that is a real, what I might call antagonist for mental health. We don't like uncertainty as human beings. We find it really challenging. I know some of you I talked to during the pandemic, there was a little bit of going, well, now they know what it's like too. We live with this all the time. Yeah, because we don't like uncertainty. We find it really challenging, and it can lead to anxiety in its own right. And those uncertainties are often day to day. Is it going to be a good day or a bad day with how I or my child is? But it's also about the long-term uncertainties too. What will the future look like? Will their condition get worse? Who will look after them when I'm no longer here? What are the services going to be like as they progress up into primary school, secondary school? Could we even look at something like university? Is that even something we should have on our radar? How do you make sense of how a condition will unpack over time? And of course, you're also dealing day to day with the low disease awareness amongst professionals, but also those around you too. I think someone spoke this morning about how helpful it was just to have a diagnosis, even if it wasn't one anyone else had heard of, but to say, yeah, we have this deletion on a kind of, it gives it a kind of authority that when you don't have a label of some sort, is so much more difficult in engaging both with professionals, but those around you. And often I've talked to people too, and they've said, yeah, we all recognise that kind of rare condition glaze over. Yeah, when you perhaps someone says, oh, yeah, so what is it that your child has? And you go, oh, it's a something deletion. And they go, right, okay. And they sort of lean out. And of course that's so painful because of course there's many other more common conditions. People lean in. I was talking to someone recently and she said, she was diagnosed with a rare condition as an adult, and she said one of the hardest things was her sister was diagnosed with breast cancer at the same time. And she said, I didn't want to take anything away from my sister's experience. But she said, what I noticed was, because everyone had heard of breast cancer, they leaned in. What can we do? How can we help? Oh my goodness, this is so difficult for you. She talked to people about her condition and they went, right, okay, so you going away anywhere in the summer? And there's something about that leaning out that people do with rare conditions, and that's why it's so important days like this, because you're all leaning in. All of you are looking at each other and going, yeah, I've got that, I understand that experience. And that in and of itself is so supportive to your emotional well-being. The emotional impact and the emotional toll that all of you are living with in an ongoing way is probably very under-acknowledged and under-recognised even by yourselves. You know, I was listening this morning to how many of you have young people who exhibit either unpredictable behaviour or challenging behaviour. I was talking to a parent recently who said, I love my daughter dearly, but I can't think of anyone else I would stay with in my life if on a nightly basis I had to put up with their verbal and physical assaults upon me. And of course, you do that because you love, because you care, because you're committed. But that doesn't mean it doesn't take an emotional toll and is hard to manage. And I know that many of you too will have had to support your young people or your children through very distressing situations. I remember when I first took my daughter for a series of blood tests which had to be taken in a particular way, and how traumatic I found it as a new parent. And my daughter was fairly, she was not young at this point. Being exposed to the level of distress that she was experiencing and having to undergo these procedures. And these are traumatic in their own right. And I think it's really important we acknowledge the sort of level of low level or sometimes even high level trauma that some of you will have been exposed to just by the fact of supporting your young people and your children, or yourselves having had things happen to you that are deeply unpleasant, deeply intrusive physically or emotionally. So I think we just need to sort of say, you are living in the world of the extraordinary a lot of the time. And that's why it's so helpful to come together, because you are all living and experiencing things that are often beyond the understanding, the experience of many of those around you. Stress and strain on family and couple relationships. I'm sure I'm not alone in that in couples, in families, there are often very diverse and very competing ways of thinking about how best to deal with different situations. whether that's a child's behaviour or how you should interact with healthcare services. There's a lot of room for conflict. There's a lot of room for difference. And that creates its own stress and strain between couples, or sometimes between extended families too. Sometimes we talk to families who are saying, this is so hard because my parents do not want to acknowledge the difficulties that my children have. They just want to brush it under the carpet. They want to say everything will be all right. And of course that leaves then someone feeling more alone. So there can be all sorts of different strategies that individuals have that might rub up against other people's about the best way to deal with difficult situations or circumstances. And the other thing that all of you here will know very well is that high logistical burden of disease care and management. You know, you all talked about that this morning. Someone talked about, you know, a really thick file. You know, you have to be super organisers. You are learning to navigate services to a degree that others may only dream of. You know, if all of you were running the country, it would probably be a really interesting situation. You know, you have to really get on top of, and it can feel like a full-time job when you're supporting a young person or living with your own condition. And that's stressful too, because ordinary life doesn't stop, as I'll talk about in a moment. And then for those of you that have inherited conditions, the implications too of what that will mean for family planning choices and thinking about more children, or your own choices around what would be right for you, and the knock-on effect on your own identity too. I think we really underestimate sometimes what being diagnosed with a genetic condition, particularly a genetic mutation, can feel like. I remember when I first got involved in this world and I was like, oh my God, my children are not mutations. Like this, it was sort of really jarring to me, the language that was used, and yet becomes so sort of second nature in a way. But I think we shouldn't overlook sometimes how these things can be painful and jar. And of course, in the context of all this, what you are working with very often is something that someone spoke so powerfully about this morning, which is that many of you have children that you love but are not the children you expected. And that is such a powerful thing to come to terms with, because it is such a conflict. How you can both love your child but also wish that things or they were different in certain ways, that life would then look different or be experienced differently. And this is hard to talk about. It's hard to acknowledge. But it's really fundamental, and this is a safe and important space where we can do that, where we can have those competing feelings of both loving and wishing things were different too. And also sometimes maybe even not liking our children very much. We can both love, but sometimes not like because of how they are. You know, back to what I was talking about how extraordinary sometimes it is when we have young people who can really challenge and really be difficult to be around, and yet we can love them too. I'm going to move on. So I'm going to offer up to you a really simple kind of image that we use a lot with the families that we work with, which is about the idea of a stress bucket. And I'm tempted to use a visual aid, but it involves using water, but I'm going to go for it anyway, and we'll just hope it goes okay. So this is an idea really that this is a very non-psychological term, okay? So this is the idea that we are all born with a kind of internal container, a kind of stress jar, which is the capacity to deal with life stuff, okay? Notice I'm using the term stuff there, not anything else, okay? This is our capacity to deal with life stuff, and we all have a different internal jar. Some of us have big ones, some of us have small ones. The size of our jar is impacted by a number of different things. Our personalities, it's affected by our genes, it's affected by our upbringing. So our jar is our capacity to deal with life stuff, to deal with stress. Some stress will be good, things like parties, moving house, new jobs, good stuff, good stress, but still stressful. Some of it will be bad stress. That's when perhaps you lose someone you love, or you're having difficulties at work, or the dishwasher breaks, yeah? So we are dealing all the time with the stress and the stuff of life. Now, when you are living with the impact of a rare condition, there is always a little bit of your glass that is full. And the way to think of it is that this is your stress jar. A little bit of your capacity to deal with stress is always going to be taken up now by living with the impact of a rare condition. So that's really important to acknowledge and recognise, because what that means is that your capacity then to deal with the rest of life's ordinary stresses and strains is going to have to be managed very carefully. And there's a dynamic relationship between these two, because you'll know that in your life there will be times when you're bumbling along relatively well. You're just sort of getting on with life in terms of the impact of a rare condition. It's kind of like you're in maintenance mode, yeah? Things are good enough. It's kind of all right. So it's trickling around there at the bottom, yeah? You'll have more room for dealing with the stress and strain of ordinary life. Life can expand a little bit. You might think, oh, yeah, I can take on that promotion at work. Or, oh, yeah, of course I can organise that 70th birthday for my really difficult parent. You know, there will be ways in which you have more bandwidth. But there will be other times when you are more involved with, or the rare condition you are supporting demands more of you. And that can be challenging because it means that sometimes you then have to adapt. In my case, often in a bit of a bad temper and somewhat reluctantly, that the demands of ordinary life might need a bit of moderating. You might not be able to do quite as much as you did before. You might even have to ask for a bit of help, which some of you will find harder or easier than others. So this relationship between your rare condition and your ordinary life is a dynamic, changing relationship. In my language, we call it psychological flexibility. And usually we run into difficulties with our emotional well-being if we get too rigid in one or the other. Because the rare condition is taking up so much of our life, we forget to sort of engage with the ordinary stuff of life. We forget to make room for it, or it becomes hard to make room for it. Or because we're sort of going, and I have done this in my own life, gone, no, this will make no difference to my life and what I'm doing. I will plough on in my life as if there is no impact from this rare condition in my life or my children. And then, funnily enough, you start to feel quite stressed. You start to feel a bit overwhelmed. And all of you will know intuitively when your stress starts to creep up. We don't always like to acknowledge it, and we don't always like to admit it, but usually we have a bit of a hunch when our stress jars are getting a bit full. You might even find yourself using phrases like, I'm feeling a bit full up. Or, I'm feeling a bit overwhelmed. That's when it's starting to come out, yeah? If you're like me, don't tell anyone this, I tend to get, when I'm stressed, either a little bit irritable, I know that seems hard to believe, or I become a bit tearful. And that's not uncommon too. My little handy hint, which is always a little bit controversial around gender, is that I think sometimes men get irritable and women get tearful. But of course, that's not a hard rule, but it's just about noticing. So what we're going to do is I'm going to make you do a little bit of work now. And I'm actually going to ask you to go into groups of 4. Just pick the person who looks most amenable to talk to, or at least the less terrifying, next to you. And what I want you to do is say, okay, let's just share a bit about what our stress signs are. I'm going to give you a little clue for those of you who are going, I've gone instantly blank, I can't think. Okay, so this is about knowing when your bucket is filling up. Okay, so there are all sorts of ways that we can exhibit our stress signs, and this is about you getting the hang of what are your stress signs. Sometimes they come out by how we behave. Sometimes we withdraw, we don't want to be around people, or sometimes we get a bit manic. We want to sort of do everything. We can take the world on, yeah? Both can be a different way of showing stress. How we think and feel. Do we start to get very negative, or do we get very sort of tearful, or do we get very sort of short-tempered? You know, does everything feel a bit much? Or sometimes our body shows us. Sometimes we want to sleep a lot or not sleep at all. Sometimes we want to eat a lot or not eat at all. Sometimes we start looking forward to that glass of wine in the evening just a little bit too much, or maybe 2 or 3, or I gave up smoking but suddenly it looks so attractive again. So there's different ways in which our stress shows itself to us. And what I want you to do is sort of be brave. Obviously, only reveal what you feel able and comfortable to reveal. You don't want to go away from this session going, I can't believe I told a stranger that about myself. Okay? So, but share a little bit about what you notice about when you're getting stressed. And then in the second part, I'm going to give you some really sort of straightforward pointers for you to take away about how to keep your stress low. So we're going to do this for no longer than 10 minutes. And I'm going to be very strict and bring you back at 12:30, okay? So groups of 4, and just introduce yourselves to each other and just say, when I get stressed, it comes out like this. Off you go. Sometimes when people come and talk to us at Rare Minds, either in our counselling services or our workshops, one of the most difficult things is allowing for the difficult feelings. And that's, of course, what's so good about events like this, because there's a kind of robustness here of being able to go, yeah, we can talk about the difficult stuff too, in a way where other people go, yeah, I get that. It's like this. And the feelings that we find come up the most in the people that we speak to are grief and loss, which I think we talked a bit about this morning, and how that can also creep up on you unbidden. We're not always prepared to be visited by an experience of grief. It can come out of the blue, but it's helpful to recognise it when it's happening. I talked to a mum earlier on in the week, and she was saying she was feeling quite steady in herself. She was feeling fine. Things were going more or less okay. And then she caught sight of her daughter attempting to get on the first rung of a ladder at a playground. And her daughter is 9, but has a lot of mobility issues. And she said, I was feeling like really cool about things, like things were fine, things were okay. And then I caught sight of my daughter struggling to do something that every other child her age and every younger child could do. And it just failed me. And she said, out of the blue, I just thought I have to get away from this situation for a moment because she needed to have a cry. And that's all right, but there will be times when you will be visited by moments of grief out of the blue. And it's about looking after yourself and saying, okay, this is one of those moments. It's all right, it's one of those. And you will have a bit of a cry, or you'll take a bit of a deep breath, and then you'll get through. But it will happen at different points and at different times. Sadness is a really interesting one that I don't think we talk enough about. One of my colleagues, a woman called Joanna Griffin, who some of you might know, who's also a psychologist, and she talks about the phrase chronic sorrow, which I think is a really lovely phrase in terms of what you all carry when you are someone who is either living with a rare condition yourself or you are parenting a child with a rare condition. Because even when life is okay and you're getting on with things, there's a sort of sadness. It's linked to that, what we were saying before, that sadness that certain things weren't just different, that bit easier, that it wasn't quite like this. There's a sort of baseline of sadness that you carry. Someone also described it, and it's to do with my other life, it's sort of some melancholy, a certain sort of melancholy you carry inside yourself that's there. And it just sits there quietly. Sometimes it pokes up a bit, but it's around. And then, of course, there's the fear. And all of you, I think, here live with a certain level of fear. What does the future look like? What does the future look like for your child or for yourself? And that's a real fear. It's not a fantasy, because things are uncertain and things are difficult in the world. And services do not function as they should. And the world can be a difficult place. So fear is not a sort of something to be brushed aside. It's a real experience that you all have. And the other one is that of hope. And hope is a difficult emotion to sit with, because we cannot avoid it, but it can also be painful. We need it, we need hope, but it can sometimes be very difficult to lean into hope because we fear being disappointed. We fear being let down, whether that's asking for help or whether that's the hope of something our child might be able to do with a bit of support or a bit more care. So hope can feel very dangerous. It can feel very risky, but we need it. And sometimes we have to remind ourselves to be brave and to hope. So sometimes when people come to us, they go, I don't want to feel like this. And I'm like, I totally get it, but feelings just are. Feelings have no intrinsic moral value. They are not good and they are not bad. One of the things that we have discovered as sort of neuroscience and psychology has got a bit more developed is this thing called the 90-second rule. And I find this really helpful. And it's the idea that rather than spend a lot of energy resisting a difficult thought or feeling, it's almost like we sort of squint at it. We go, oh yeah, that's anger, or that's guilt. Yeah, you know, the sort of guilt one where I should be doing more, whatever the situation is. So there's something about being able to squint at a feeling and say, I recognise you, I know what you are, okay? And if you sit with that, for they're saying roughly a minute and a half, it starts to feel less intense. Now that's really helpful because it means that we're spending time then letting a feeling pass, letting it move on, rather than it getting clammed up inside and spending a lot of energy resisting it or fighting it. Practice self-compassion. That's a sort of slightly fancy way of saying be kind to yourselves. One of the things we notice a lot in Rare Minds is how often people come to us and saying, but I should be doing this, I should be doing that, I haven't done this, I haven't done that. Or a lot of shame about the very difficult experiences and feelings that might visit, often late at night, or the way one parents when one is not parenting in public, the things you say to your child, or the things that you think, oh yeah, I'm really glad no one actually saw me do that at that particular point, yeah? So those sort of, you know, those really sort of difficult experiences and feelings that we have in private, except you will not always be the parent or the person you wish to be. And if you take away anything from this, take away that. There's a really great psychotherapist called Winnicott, and he has the idea of being a good enough parent. By virtue of the fact that all of you are in this room thinking about your children, I can pretty much guarantee you are good enough parents, okay? So focus on being good enough, not on being perfect or on being better. Try and not make comparisons. You know, we're sort of built to do this as human beings. We make comparisons with what other parents are doing. Oh, they're doing more than me. They've got this in place. Oh, they're doing that. Or they're parenting better. Or we make comparisons around our children. You know, someone was saying this morning they weren't quite sure they could speak about their difficulties because other people have it worse. But we all sit within our own experiences. Our lives are difficult for all of us as individuals in our own way. Rest in that. Own that. You don't need to compare. Notice when your bucket is filling up, just shove that in there to get the message home. Let go of the guilt and the shoulds. Yeah? So really, really challenge yourself when you start having those thoughts about I should be doing, I am not, I should be. The shoulds are always a little clue that actually you need to watch your own sort of your own guilt levels and your own ambitions, which are often quite harsh, you know, and we all fall into that. I run a small charity, and I should tell you that I spend my life thinking about all the things that we should be doing rather than celebrating all the things that we are. And I'm offering that up to you in your own lives too. Celebrate the things that you do, because you are all doing a lot. And as I said before, aim for good enough, don't aim for perfect. Learn to tolerate uncertainty. It sounds so glib when I put it like that, doesn't it? Just learn to tolerate uncertainty. This is one of the hardest things you will have to come to terms with when you are living with a rare condition. We don't like uncertainty. We so don't like uncertainty that we manage it in a slightly cack-handed way. So rather than sort of saying to ourselves, well, I don't really know what's going to happen in the future, or I don't really know what that would look like, we stuff that void usually with all our worst fears and worst scenarios. Yeah? What if this happens? What if that happens? We try and imagine all the scenarios and then try and deal with them. And this means that we're using emotional energy before we actually get there. Now, that is not to say there is not a sort of pragmatic wisdom in being able to look ahead and, as someone was saying this morning, think about things like, when any of you are not around, who might care for your child, or start putting things in place financially or practically. But we also spend a lot of time worrying about things that may or may not happen. And what I want you to encourage you to do is to, when you start having those sort of what-if scenarios, and you start, you can sort of rumbling about what if, try and bring it back a bit. I sometimes think of a fishing rod, reel it in a bit and go, I don't know. I have to sit with the not knowing for now. And that's all right. And when I get there, that's when I'll deal with it. And have confidence in your capacity to deal with things that might lie ahead. One of the things I often say to people is that we are often much more resilient and robust in things that we fear than we think we might be. Yeah? Human beings are extremely resilient and creative. You might have all sorts of fears about what the future looks like. It probably won't look quite like you imagine it will. So to some extent, deal with it when you get there. So this is where I often say, think about that stage, we're not there yet. I'll deal with it when we are. So I'm going to give you a really quick little exercise. And I love this because this is one that apparently they teach to Navy SEALs, okay? So I reckon if they teach it to Navy SEALs, it's good enough for those living with rare conditions because they're sort of similar in lots of ways. So what I want you to do is just put your feet, if you really don't want to do this, just look at everyone else doing it and sort of cross your arms. But if you're up for doing it, just put your feet on the ground. And this is called box breathing. Okay, and you can do this anywhere. You can do it at home, you can do it late at night, you can do it in a waiting room, you can do it when you're dealing with a doctor that you probably want to murder. Don't do that, it won't go down well, okay? So put your feet square on the ground, and I want you to put one hand just over your heart here. And what I want you to imagine in your mind is a square box. And we're going to start at one corner, and we're going to take a deep breath in to the count of 4. Don't do it for a minute, okay? Then we're going to pause for 4, and then we're going to breathe out for 4. And then we're going to go pause, breathe in, pause, breathe out. And you do each side of the box on a count of 4. Some of you are already looking confused. We're going to do it, okay? So feet on the ground, hand on your heart. Okay, so we're going up the side of the box with a deep breath in. Pause, 1, 2, 3, 4, out. Pause, 1, 2, 3, 4, in. Pause, out. Pause, in. Pause. 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 And stop. I'm hoping your shoulders all feel a little bit lower than you did when you started. But it's an exercise to practice on your own and also offer up to your children too. So this is called box breathing. Think about 4. There's lots of little resources on the internet that can help you. This is something that actually my therapist said to me once, which was probably the most helpful thing she ever said in the time that I was seeing her. So I'm passing it on as a freebie, which was just do the next thing. When we are feeling overwhelmed and in the grip of stress, we often can't think. We don't know which way to turn. There seem to be so many demands upon us and upon our time. And you are managing, as a group, much more than many other people. Your bucket is always intrinsically fuller. And exhaustion and burnout are real risks for parents and caregivers. You know, looking after your emotional well-being is part of what you need to be doing as parents or individuals. So pacing is a key skill to learn. And one of the sort of skills in pacing is being able to say to yourself, what is one thing I can or need to do next? So you know when you're in that grip of like, I just don't know what to do next, there's so many demands upon me. Just do the next thing. Do the most pressing thing. Then do the next thing. And stepping back and saying no can be really difficult because all of you here by temperament are probably doers. Yeah, that's probably why you've turned up here. We're going to do this better. We know how to do this, yeah? You're all active people by virtue of the fact you've come today. So being able to be someone who also gives yourself permission to step back, to say, no, unfortunately, I can't do that today. That may be something I need to leave till next week or next month. These are really hard skills to learn because they make us come up against our limitations. And none of us like to have limitations, really. So think about when you are in the grip of that sense of overwhelm or burnout or exhaustion, what's just one thing I can do? And just do that. Then rest, pause. What might be the next thing? It's a bit back to that principle. Everest is not climbed in a day. That's why they have all those base camps. Yeah, you've got to get to the next base camp. Oh, thank gosh, now I can relax. And you rest, and then you do the next bit. That's a good metaphor for living with a rare condition. Find your community. I cannot emphasize this enough. And of course, for all of you here, unique is your community. It may be one of several communities, but is certainly a community that is available to you. And the proximity that you have to your community, as someone was saying earlier, may fluctuate over time. You don't always have to be very involved. Sometimes you may just want to stalk what it's doing for a bit before you think, oh, I might go to something then, it looks sort of all right. You may have different paces of involvement with communities at different times. People like unique. Like someone was saying earlier, autism communities, special educational needs communities. Perhaps groups that support you if you're dealing with anxiety or challenging behaviour or depression. There's lots of different sorts of communities out there. So these are really important communities to be part of. It's why Rare Minds set itself up, that one of the things we want to say is that there is also a community that supports you with your mental health. Because being attached to others, being in a room with or around others who know exactly what you're going through is one of the most protective things that you can do for your own mental health and well-being. And I'm actually going to just make you stop now for a minute. I want you to look around. And I'm going to finish in a minute. But I want you to look around. So you'll have to swivel. This is where you have to actually do that. You have to swivel, and I want you just to look at each other. Okay? Now, the reason I'm asking you to do that is because when you go home, and when things are tough, and when you are feeling on your own, and on your beam end, and I'm not even sure I can do this anymore, and things are hard, or late at night when you're lying there in bed worrying, think of this room, okay? Because in this room, there are other people who know what you're going through and what life is like for you. And that in and of itself is one of the most important things that you can take away from today. Whatever you remember from my talk, remember this, okay? Now, we were talking in one of the sessions earlier, and I'm not going to spend a lot of time on this. It is hard, I understand, accessing support if things feel really tough. But if you are struggling, if you know that your mental health is really struggling because of what you're going through, there is help out there. Again, it is something you might need to persist in getting through to, but there is help there. There's a very good NHS website which has lots of self-help resources on. If you haven't come across a website called Affinity Hub, that's a good wellbeing support service for those with children with special needs. And some of you here might have had counselling in the past, and you might think, oh, it was great, it was really helpful. And some of you might go, no, it didn't work for me, didn't get on with the person, it wasn't my thing. Don't give up. Sometimes we need to find our way to the type of support that works for us. For some people, that might be groups. For some people, it might be finding a way to the right sort of therapist with the right sort of approach that works for you. And particularly, I would also say, for those of you here as couples or in a couple relationship, I really understand how much room there is for conflict when you are parenting a child with a rare condition. Personally, I think sometimes standard couples therapy should be made available to all families who are dealing with challenging situations like yours. And what I also want to say is there are couples counselling services out there. Don't dismiss that as a source of support for you, because you're people first, not just parents. Yeah. So spending time looking after your couple relationship when you're parenting is really important too. And I've just put some crisis support services on there so that you have those too. So I'm going to stop now. I am just going to say one thing, which is that Rare Minds is developing a wellbeing resources hub on our website. So if you want to hop onto our website at any point and sign up to our mailing list. That's something that we can also let you have access to and will be freely available to you. So we are a small organisation, but we are hoping to grow and doing our best to support your emotional well-being. And I know I've run a little bit over time, so thank you very much for your forbearance on that, and thank you, Sarah, for inviting me.
Thank you so much, Kim. That was really fantastic, I think. I think there were so many things that spoke to all of us, and we all need to be more mindful of that. I'm here in my capacity as Chair of Trustees of Unique. I've been knocking around for a while because I've got a son who's 22 years old, Max, and he's got a rare chromosome disorder, and I share every single emotion and story that's been told today, highlights and lowlights. And he was diagnosed at birth, and I had probably a quintessentially unique experience in the sense that we were immediately told there's something wrong. I felt absolutely devastated because Max, my unborn child, was, he was going straight to Oxford, and he was going to be here today in his capacity as lead genomics lead for the whole of the NHS. And I mean, yes, it was complete incomprehension and, to be honest, devastation that suddenly that's not what it was going to be. And if there was one thing I knew, it was that I was not going to cope as a parent of a disabled child. Hey ho, here I am. And he's 22 now. He's in his last year in residential college at St John's in Brighton. And I've travelled so far because I used to dread the future so much, that sense of uncertainty, or worse, certainty that it would be all awful and wouldn't be anything there for him, blah, blah, blah. And now I'm actually quite excited because he has changed so much. I have had so much fun over the last 22 years, and I have learnt so much, and it's been pretty exciting. And I'm slightly glossing over some of the more difficult moments there. Now, one of the things that's been fun and interesting has been getting involved in Unique, and I first limped through a 5K run sponsored for Unique, and one of the most painful moments of my life, Battersea Park, and started doing a bit of fundraising, a few cake sales, and getting my colleagues at work to sponsor me and things like that. And I gradually got involved and became a trustee quite a long time ago. And what's been really amazing is actually seeing what Unique does. First of all, of course, it provides me with all the companionship and help and support. And it was that classic moment where I rang Bev Searle, our previous CEO, before Sarah very kindly took over when Bev retired. And she put me in touch with one person across the world. And I had that trigger moment where, from absolute devastation, the mother said to me by email from Singapore, my daughter Juliet goes to nursery, she understands English, French, and Sinhalese English, and she loves Pelmanism pears. And suddenly, Henry and I were just like, oh my God, I mean, that's like a normal nursery experience. And it was life-changing. And needless to say, our geneticist had said he might never talk, he might never walk, Anyway, Unique, I mean, at the time there weren't guides, and since then there's been a fantastic guide to Max's chromosome disorder published, and it's been revised. And thanks to everyone answering and updating their questionnaires, it's now a 50-page document, and I can whack it on the table with all the other documents recommended today to intimidate people, because it's great having a chromosome disorder because no one in the room knows anything about it, let alone more than you, so you can wave that rare card. And one of the things I've learned from my involvement with Unique as a charity is that there are more of us, people with children and adults with chromosome disorders, than autism, Down syndrome. And you wouldn't believe that if you looked at the services available and the focus on those areas. And our problem, in a sense, is each of us, our children, being rare. And that's also, and for Unique, we do an extraordinary amount of work. We've gone from, I think, 1,500 members when Max was born to 28, 29, 30,000. And we do that with no state support, and we get great gratitude and thanks from geneticists and doctors for what we do. But at the end of the day, and the basis for all of that is all the information, the day-to-day database forms that you get sent from time to time. And our staff do an absolutely amazing job producing all the guides to chromosome disorders that were mentioned by Eamon this morning, and answering the helpline, you know, when we ring up and say, you know, have you ever heard of this extremely weird condition that my son seems to have, and what can we do about it? And they look at the database and they say, oh, there's somebody in Canada who's mentioned that. And all of that's done by Sarah and Francesca, Claire, Anita, Louise, who are in the room, and many more staff members and how do we do that? We do it entirely for free for members, because the most important thing for us is that we get as much data to inform our guides and so that we can answer all these questions. So one of the puzzles when I became a trustee was, why is it free? It costs £35 to join the Down Syndrome Association, and it's free to join Unique. And the reason is because many of you, I know, have run marathons and nominated us for Charity of the Year in your children's schools and at work. And I'm sort of concluding, you can see where I'm going, can't you? I'm concluding today by saying we do an amazing amount of work. I think we all agree. We would like to do more, so we'd like to keep supporting everyone through the whole journey into adulthood. And but at the end of the day, we appeal to you, because the most important thing you can do for us is to keep filling in those questionnaires that we send you, telling us about your children and adults as they grow up, because that will inform the research and the papers. And everything to do is based on this huge database that we hold and that answers so many questions for so many people. And then the other thing is, you know, I think, Kim, I'm not sure I saw a slide about one of my coping strategies, my main one. It's distraction. So I'd much rather sit in a Unique trustees meeting than discuss my son's chromosome disorder and attend an annual review. That's very low down on my list. And, you know, actually nothing's given me more pleasure and joy than getting involved in Unique. A, because it distracts me from the day-to-day problems, but also it's just amazing what we do, or what you guys, the staff, do. And all I can do is encourage you to get involved, and we're always looking for new trustees, because Jill's retiring after years and years of service, and Edna's still a trustee. She was the lady who set up Unique 40 years ago, almost 40 years ago.
40 years next year.
Yes. And we're always looking for new trustees and Unique and volunteers and local contacts, and we also have highly prized marathon places. Have any of you reached the midlife crisis moment when you're suddenly watching your gut microbiome and thinking maybe a little bit of running? Yeah, just putting it out there. We've got 8 bonded places. And, you know, thank you so much to all of you who have done so much for Unique in every way, and just by being here and encouraging us. And just stay in touch and tell us what you want us to be and do, because, you know, we're always evolving and we're growing. And we really hope you've enjoyed today. I've really enjoyed it, and it's been like a spiritual top-up, dare I say, and also knowledge top-up, because I've attended 10 million challenging behaviour workshops, and every time I learn something more, I'm reminded of something that I should really be doing. And then, of course, I'd like to thank the RSM, because they very kindly made this possible and gave us this fantastic venue. It's so nice not to be in a slightly shabby church hall, because that's normally where special needs events seem to take place. And thank you, Shweta, for making this happen in the first place and being the link with the RSM and putting us in touch with them. And thank you, everyone, for being here and for organising it. And I do hope, if you can come and join us for lunch at John Lewis. And if not, just stay in touch. And thank you.
I think our time has come to an end. Actually, one thing that we haven't said was we actually tried to make this a whole day event, and we only had a morning, so we've tried to cram everything in. I hope it's been a really good day. I've really loved meeting so many of our families, and I hope, as Sophie says, you keep in touch, and hopefully some of you can come and join us for lunch. But thank you for coming, and thank you. And if you're not a member of Unique, please get in touch. Either grab one of us and you can join, or email us and you'd be very welcome to join. So thank you everyone for coming, and yes, we'll keep in touch and keep the Unique community growing and thriving.